Hello, everyone, and welcome to today's webinar, Illicit Opioids, What You Need to Know. I'm Cassie Saltman of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Abbott. To learn more, visit www.abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box to the left and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker for today's webinar, Dr. Patrick Kyle, Professor of Pathology at the University of Mississippi Medical Center. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Kyle, you may now begin your presentation.
Good day, everyone. My name is Patrick Kyle. I'm the Director of Clinical Chemistry and Serology and Toxicology at the University of Mississippi Medical Center. And today I'll be speaking about the illicit opioids and some things that you need to know. I do need to disclose that support for this program is provided by Abbott, and that the information is based on my interpretation of the evidence and lots of clinical experiences. Now, objectives for this presentation. At the end of this presentation, you should be able to identify dangers of illicit opioid use as well as misuse. You should be able to relate positive outcomes of drug testing, and you should be able to discuss methods to prevent and to treat opioid overdose. Now, we all know that drugs of abuse are prevalent in our society in the United States, as well as societies across the world, and they have been for many decades. Drugs of abuse are commonly used by teenagers as well as adults, and we see images here of everything from alcohol to white powders and naturally occurring substances. As I completed my training and board exams, I was surprised to learn that there was a monthly publication called High Times Magazine that was in production and had been since the 1960s. And this is in the mid 2000s, before any states had legalized marijuana or anything like that. So I was surprised by that. We'll go ahead and advance. As we talk about drugs of abuse, I'd like to talk about some things that have influenced or that do influence individuals to use and misuse drugs, compounds, and chemicals. And these may be prescription medications as well as illicit or street drugs, as they're commonly referred to. And we all know the effects of peer pressure. We felt peer pressure since we were in elementary school, grade school, and middle school, and we know its effects. But data has also shown that individuals that go on to become addicts often became exposed to opioids during a medical or dental procedure when they were in their teenage years. And this could have been during a tonsillectomy or afterwards, or it could have been wisdom tooth extraction or something like that. But as they were prescribed those pain medications, they recognized how potent they were and how they made them feel, that light, airy, floaty feeling that alcohol and some other drugs can cause. Other influences. Drugs have been sensationalized or glamorized by societies. In fact, we've seen them in our television shows or television series. Here's some titles here, as well as in the music lyrics of popular songs from some groups way back in the 60s up to current day. We can see that. In fact, I had the opportunity to attend a national toxicology meeting not too long ago. And as I got outside the convention center and seeking a restaurant, some of the local restaurants were aware of the content of the meeting And this restaurant had displayed or relabeled their sandwich menu. And so on the left here, we could see that in that restaurant, and these were displayed outside the restaurant. We could see that you could purchase their Vicodin sandwich. Vicodin is a prescription medication that contains hydrocodone and acetaminophen. So they labeled it the Vicodin sandwich because it's a grilled cheese sandwich, but it's made with pimento cheese, with those roasted bell peppers or red peppers that must have been quite addictive. And you can purchase that sandwich with what they refer to as an $8 copay. Or if you needed something to calm you down, you could purchase their traditional grilled cheese sandwich, their Xanax sandwich, as they labeled it for that week, for a $6 copay. And if you were watching your cholesterol and et cetera, you could eliminate any meat or anything and purchase their Lipitor sandwich. And over on the right, we see that they had listed an Abilify sandwich. Abilify is a prescription antidepressant that may be added with other medications. So that Nutella and those strawberries on chocolate bread, boy, that must really lift your spirits, and et cetera, et cetera, et cetera. So we see how drugs and pharmaceuticals have become popularized by society and media. Now, the purpose of this presentation today is to increase the awareness of side effects of opioid abuse and misuse. So for August 31st, we celebrated International Overdose Awareness Day, and you may have seen some of that in the news media. The month of September has been designated as National Recovery Month for addictions. And today, September 21st, is designated as National Opioid Awareness Day. Now, the United States has been fighting an opioid epidemic since the mid 2000s or 2010 era. The latest information that I've been able to obtain from the CDC is that almost 200 Americans died every day during the year of 2021 from opioid overdoses. In fact, there were approximately 107,000 drug overdose deaths in the United States in that year. And of those, 80,000 were from opioid overdoses. So that's almost 3/4 of the deaths from drug overdoses were due to opioids. Of those opioid overdose deaths, almost 90% involved synthetic opioids. And this has been a trend over the past several years, and we'll get into that a little more. But from the year 2010 to 2021, we saw that overdose deaths from heroin increased threefold, and that is significant. However, in about the same time period, we saw that deaths from synthetic opioids increased 20-fold. So I know that in our data looking back in 2005, 2010, and I've got a couple of slides to illustrate, but most of the opioid overdose deaths were from prescription opioids, your hydrocodone and oxycodone and those type things that are prescription medications. So in the past 5 to 8 years, we've gone from that to most deaths from opioids occurring from synthetic opioids. And we'll go into more of a description of synthetic opioids in just a moment. But more information. How did we get here? A little background information is in order, as this presentation is targeting members of the general population. That could be mom and dad at home or teachers, as well as laboratory professionals and individuals working in clinical and hospital laboratories, as well as clinical providers, nurse practitioners, and physicians that may be prescribing medications. So in the year 1996, Purdue Pharma released their medication called OxyContin. This was a long-acting, or what they refer to as an extended-release oxycodone preparation. So consuming a single tablet, you would get a bolus of oxycodone to knock out that breakthrough pain, but then there would be an extended release of that medication for the next 12 hours and sometimes 24 hours to maintain a constant blood level of this opioid analgesic. In addition, members from the pharmaceutical industry began lobbying physicians as well as Congress to establish pain as a fifth vital sign. Now, we know that the 4 vital signs in patient care that we always monitor are heart rate, respiratory rate, blood pressure, as well as body temperature. And they had lobbied that pain or management of pain should be considered a fifth vital sign. And so suddenly, our physicians were being graded or evaluated on their management of a patient's pain level. Now, as you may understand, pain cannot be readily measured by any monitor or meter or anything like that. And so it's a very subjective thing to evaluate a patient's pain. And so questionnaires were completed and given to patients about their pain level. Please rate your level of pain from 1 to 10. And as you know, it's very easy to say 7 or 8 or 9. And so patients obtained pain medications very readily in the late 2000s. I recall during 2005, I had an accident and crushed the smallest finger on my right hand. It was a tractor accident, and I arrived at the emergency room, and they flushed that wound, sutured it up, the bone was crushed, all that sort of thing. And they prescribed me hydrocodone and acetaminophen preparation. I think it was 1 tablet every 3 to 4 hours as needed for pain. And they gave me a prescription for 15 days worth. So I got the prescription filled and had approximately 60 tablets there. And I did use that pain medication that first day. But after that, I really didn't need it. Yes, there was a throbbing sensation with all the swelling associated with that. But I found that I really, that over-the-counter acetaminophen or ibuprofen would take care of that pain. But prescription and prescribing of opioid analgesics during that time period was very widespread and very liberal. And so it affected patient care, and patients became readily addicted. Oftentimes, physicians were informed or taught that as long as that patient has pain, then they cannot become addicted to opioids. So if they've got pain on board, they're not going to become addicted. And that is simply not true. I know that it's very easy to become addicted to opioids. In the laboratory, in the experimental laboratory, we can use high doses of morphine infused into rodents, mice, and rats that we experiment with for addiction. And those mice and rats will become addicted within just 3 to 4 days. Now, we measure that and can verify that in that once those opioids are withdrawn, the rodent exhibits weight loss, they exhibit teeth chattering, as well as shaking and what is referred to as wet dog shakes. And these are the side effects of opioid withdrawal. So if we look at the most widely prescribed medications over the years, hydrocodone was the most widely prescribed or the highest prescribed medication for 8 to 10 years. In 2010, it was number 1, but you also see there a statin, simvastatin, which is for cholesterol reduction. You also see lisinopril, which is an ACE inhibitor administered for blood pressure reduction. Levothyroxine for thyroid disorders, and amlodipine, also a blood pressure medication. Fast forward to the year 2016, hydrocodone was also the most highly prescribed medication in the United States. And we see others. Levothyroxine has gone up. Prednisolone, lisinopril is a blood pressure medication, and amoxicillin is an antibiotic. And so for 8 to almost 10 years, hydrocodone was the most highly prescribed medication in the United States. And we began to recognize that in about the year 2010. And so I've got some data published by the Centers for Disease Control and Prevention that shows the number of opioid dispensing rates per 100 persons in each of these states. And we see that in many states, over 100 prescriptions were prescribed for each 100 individuals in a given state. Now, I know that for, during the years 2010 up until now, I've not received a opioid prescription. So lots of people were receiving multiple prescriptions, and we know that it became a very lucrative business to sell prescription medications on the street. So an individual might go fill their hydrocodone prescription at the local pharmacy for, say, a $6 copay or an $8 copay if they've got medical insurance. And they might receive 30 to 60 tablets, and they would be able to sell those tablets for $5 to $10 each on the street if it was oxycodone or hydrocodone. We fast forward, we start recognizing this in about 2010 that this was a problem, and the DEA started cracking down on many prescribers and started overturning many prescribers that were giving out multiple prescriptions per individual, per visit even, what they refer to as pill mills. And so by the year 2015, things improved. The rates of prescription went down. So this is 2015 data here. But we see that we still had several states, especially in the Southeast, with over 100 prescriptions for opioids for each 100 individuals in that state. And then we fast forward to 2020, and we've made great strides to combat the abuse of prescription opioids. Now, we know that a lot of this was due to physician education and prescriber education. And in fact, in 2016, the CDC published their guidelines for prescribing opioids for chronic pain. And this went a long way. In fact, our state, Mississippi, developed our medical licensure board worked with our state legislature to enact some prescribing laws that we'll go into in just a moment. But the CDC's guidelines for prescribing opioids for pain have been recently revised in November of this past year. And they're presented here as the 2023 prescriber recommendations. And these are recommendations. But the verbiage is very appropriate. Number one there is to help clinicians recognize that non-opioid therapies can be at least as effective as opioids for many types of acute pain. So a non-opioid therapy, that would include things like non-steroidal anti-inflammatory medications such as over-the-counter acetaminophen or ibuprofen and others. Also, number two, non-opioids are preferred for subacute and chronic pain. So acute would be pain that lasts for approximately up to a month, and then subacute would last 4 months, and then chronic for longer than just a few months. And then number three, when opioids are needed for acute pain, clinicians should prescribe no greater quantity than needed, and et cetera, et cetera. So our state worked, again, with the state legislature to enact some laws for prescribers. One of those was that the prescriber must check the electronic prescription monitoring database in our state prior to prescribing any new opioid or benzodiazepine prescriptions. And this was wonderful. This kind of cut out an individual obtaining multiple prescriptions from different doctors, or doctor shopping, as it's often referred to. Another requirement was that quarterly drug tests must be ordered for patients prescribed opioids for chronic pain that was non-cancerous and non-terminal pain. So you have the individual with, we'll say, chronic back pain from sciatica or et cetera. They must now order a quarterly drug test on those individuals. Now, it did not go into say the type of drug test that was required, but they do require drug tests. And another was that prescribers must limit each opioid prescription for acute pain for only 10 days. Now, they may write them a second prescription that could be filled after that, but the initial prescriptions must be limited to only 10 days. So what's going on now? So what's up with the illicit opioids? These things went a long way to address the prescription opioid abuse that was going on, but we saw in the year 2020, we've made great strides in that, and we see in the 2021 data that almost 90% of opioid overdose deaths result from synthetic opioids. You've probably seen in the news issues of drug busts involving fentanyl. Fentanyl is an opioid analgesic that is 80 to 100 times stronger or more potent than morphine. It's 50 times more potent than heroin. So it's very potent. It does not take much of that medication to induce pain control. And the drug cartels have latched onto this. They like selling fentanyl. Fentanyl is actually much less expensive to produce than heroin because they don't have to cultivate the poppy plants and harvest the resin and then extract the heroin and other opioids from the resin and bring it before they bring it to market. Fentanyl is a purely synthetic product. It can be made in the laboratory in pound and kilogram quantities at a time. And so we know that most of the fentanyl and synthetic opioids are being produced in Asia and China and other nations. They are coming through our southern border, as well as through the mail on occasion. But fentanyl, being 100 times more potent than morphine, only requires 0.1 milligrams for a therapeutic dose, whereas morphine often requires 10 milligrams. It's a very small amount of fentanyl that will cause death. So drug dealers like it because you don't need as much drug for a dose as well. And we see in this news blurb from 2018 that there was a confiscation of 100 pounds of fentanyl, which contained more than 18 million doses, which was enough fentanyl to kill all the residents of New York City and New Jersey combined. So it's a very potent drug. In 2017, the U.S. Attorney's Office indicted a Chinese national, Mr. Yan here, who was 40 years of age at the time, for illicit manufacture and distribution of fentanyl analogs. And he was operating 2 chemical plants in China, but they were able to arrest him here domestically. So that talks about fentanyl analogs there. What are those? Those are structurally similar to fentanyl, but the chemists have altered a chemical side groups, changed an oxygen to an amine, or changed a hydroxyl group to an amino or a methyl group, or maybe they've added something. And many of these compounds are as potent as fentanyl, and many are more potent than fentanyl. There are 50 to 70 fentanyl analogs or fentanyl derivatives that we are aware of clinically, and many of them are being sold on our streets domestically. And so when you see a news blurb of fentanyl, most of the time law enforcement has a little test kit for fentanyl and analogs, and they just simply label it as fentanyl. Even more recently, just in the past few months, fentanyl drug bust nets 300,000 pills and 11 pounds of powder in Chicago. Another 4.5 million fentanyl pills and 3,000 pounds of methamphetamine seized in Arizona. So this is not stopping. It is very widespread. The drug cartels have caught on to this. They're making lots of money, and people are dying. And we'll talk about that in just a moment. So the effects of opioids. Opioids inhibit the central nervous system. So it does inhibit the norepinephrine and neurotransmitters that are conducting the communication in your neural pathways, and that's how it disrupts pain. But it also affects the neurons in the central nervous system, in the brain and in the spinal cord. And we know that opioids will decrease your respiratory system as well. It does increase your endorphins and enkephalins in the brain, and those are the chemicals that cause the euphoria or lightheadedness or floaty feeling that's associated with many of these drugs. So it does cause an analgesia and a euphoria, but our cells do adapt, and they become tolerant to the effects of these compounds. As a result, the receptors on the surface of the cells are downregulated, and we can build up a tolerance to those. And so individuals who are using these compounds require more and more drug in order to achieve the same effect. And as a result of that, individuals develop a dependence on the drug, and that goes to an addiction. Now, we know, we've all observed that compulsive drug use can be very detrimental to an individual's relationships, not only their family relationships, but even their friends. And it can affect one's job and their ability to function in society, as we've seen in the news outlets. So the addiction can progress, and an overdose can occur, and overdose can often cause death, especially with these highly potent fentanyls. It was the music artist Prince that succumbed to fentanyl just a few years ago. He consumed what he thought was a tablet of Vicodin, a prescription hydrocodone preparation that one of his bodyguards or friends had obtained for him, and it actually contained fentanyl, and it was enough fentanyl that caused him to die. Other effects of opioids. We talked about the analgesia and the euphoria, the central nervous system depression that will cause sleepiness or stupor, slurring of the speech. It'll cause itching of the nose as mast cells within your bloodstream release histamine, and your face and nose will itch. Opioids will cause meiosis, or constriction of the pupils, which is defined as a pupil diameter of anything less than 2.9 millimeters. One thing nurses and doctors often don't tell you or warn you about if you are prescribed opioids after a surgery or other medical procedure is that they will cause constipation. And as we discussed, they will reduce your inhibit your respiratory center and cause respiratory depression. As an individual starts coming off of the opioids, they often exhibit compulsive behavior or anxiety or anger because they're no longer under the effects of the opioids, which induce that euphoria, and they become very agitated, or agitated very easily, if you will. So how do we detect the opioids? There's several different ways, and we'll talk about some laboratory methods, but we'll also talk about some methods for home use. So there are two general methods. One would be rapid immunoassays, in which a manufacturer has developed an antibody that recognizes and binds to a structure that's similar to all these opioids or fentanyl analogs. Many of these are point of care tests, kind of like your home pregnancy test. And we've used immunoassays in our instruments in laboratories for many years. There's also mass spectrometric methods, which may involve gas chromatography, mass spectrometry, or liquid chromatography, mass spectrometry, or other methods. And these will not only detect a class of drugs like the immunoassays, the mass spectrometric methods are definitive methods, and they can actually tell you exactly what drug would be in that preparation. Whereas the immunoassay screens would simply tell you that, yes, this individual is positive for the class of opiates, or the class of benzodiazepines, or the class of amphetamines. So the immunoassays can be made sensitive to their drug targets, but since they react to multiple compounds in a class of drugs, they can also react to molecular structures of other drugs if they are similar in structure to the opioids or to their drug targets. And so they can be prone to false positive results. Whereas in the laboratory, we know that false negative results can result from dilute urine specimens or new structurally unrelated drug formulations. And we'll go into that in just a moment. So as an example, we recently had a 30-year-old female that was transported to our adult emergency department. She arrived unresponsive after injecting heroin. The background on this, I did go interview this patient in the ICU as she was recovering. She had a small child, and she had gotten behind on her rent at her apartment and was kicked out of her apartment. And so she arrived at her boyfriend's house and very stressed out and anxious. And she went into the bathroom at her boyfriend's house to inject heroin. She was a previous heroin addict. She went into the bathroom so that her small child wouldn't see her doing that and try to shield her child from that. The boyfriend noticed that she did not exit the restroom in a timely manner. He became concerned and went in, and she was lying on the floor unresponsive. Now, when he immediately called 911, and when emergency medical services arrived, they administered naloxone. We'll talk more about naloxone in just a moment. And she did respond to naloxone. So she regained consciousness and began breathing again. When she arrived at the hospital, she was placed on an intravenous infusion of naloxone. And when I interviewed her, she told me that she had taken 3 Xanax tablets, or what she thought was Xanax, and she had smoked marijuana, and she had injected heroin in order to relieve this anxiety that she was having from being thrown out of her apartment. So the lab results from her urine screen were positive for the class of benzodiazepines and cannabinoids. And she had admitted to smoking marijuana and taking Xanax. Xanax is an anti-anxiety medication. It's alprazolam, and it is one of the class of benzodiazepines. So this is what you might see as far as results from an immunoassay screen. It will tell you if an individual's specimen is positive or negative for a class of medications. Our laboratory functions as a regional toxicology laboratory. So we utilize definitive techniques, specifically GC mass spec and LC mass spec, to identify specific drugs that are involved in patients. And we serve hospitals from across the state of Mississippi. So our GC mass spec results, we were able to identify nicotine and codeine. So she had smoked tobacco, as well as diphenhydramine and phenylpropanolamine. Those are both antihistamines, and drug abusers often take them to combat the itchiness that occurs from the opioids. Sometimes their skin will itch. Most commonly, it's simply their nose and face. We also identified fentanyl and norfentanyl. We did not see any heroin in her specimen. By mass spectrometry, by LC mass spectrometry, which is a confirmatory technique that we use for our immunoassay screens, we were able to identify alprazolam and hydroxyalprazolam as causing the positive for benzodiazepines. And we were able to identify a THC metabolite in the urine of this young lady as the product or the compound causing the cannabinoid screen. So a red flag here is the opiate screen was negative, and this is not uncommon. We'll go into that in just a moment. But the individual did have fentanyl and norfentanyl on board. So why was the opiate screen negative? Well, the common opiate immunoassay screen has an antibody or is engineered with an antibody that detects your common opiates or your naturally occurring opiates from the poppy plants. And these are codeine, morphine, hydrocodone. You can see how similar these structures are, and you actually have to look closely to determine the differences in these three compounds. So the antibody recognizes and binds to the structure that is common to the class of opiates, the naturally occurring opiates. But now we have opioid compounds that do function like the opiates, but they are synthetic. These include fentanyl, tramadol, buprenorphine, and others. And as you can see, these chemical structures look nothing like the codeine, morphine, and hydrocodone that we see above. We talked about fentanyl and fentanyl analogs. Oh, I'm sorry. I'm getting ahead of myself. So I went back to, as I was interviewing this young lady, she had related that she had injected what she referred to as concrete heroin. And being naive, I asked her, what in the world is concrete heroin? She said, well, it's in kind of a rock. It's very hard, pressed together. Some people refer to it as dog food heroin because it's so hard, and you have to break part of it off and mix it up in water or something before you inject it. So I often work with our local crime laboratory and law enforcement agencies, and I was able to photograph several heroin samples that were confiscated during drug busts in our area. The crime laboratory technicians told me that each of these specimens contained fentanyl and fentanyl analogs. Some of them may have contained heroin, but each of them also contained fentanyl. And so we see a pure white looking fentanyl. Back in the 1980s, that was often referred to as China white. We see a tan colored powder here, a dirt colored powder, and then the hard rock formation, which this young lady had described as concrete or dog food fentanyl. So simply by looking at a batch of heroin, one would not be able to determine if fentanyl was in that batch or not. So this screen illustrates 6 different fentanyl analogs, and you can see their structures. And there are 50 to 60 to 70 of these. They include things like acetyl fentanyl, butyryl fentanyl, alfentanyl, remifentanil, and sufentanil. Carfentanil is one that is very potent. It was manufactured for veterinary purposes, for use of an anesthetic for horses, elephants, that sort of thing. And it is reportedly 1,000 times more potent than fentanyl itself. So another case that illustrates what can happen. We had a case in which an 8-year-old child had a headache, got home from school, had a severe headache. And the child's uncle, who was at the house for him when he got home from school because mom was working, gave him what he thought was an oxycodone tablet that he had obtained from friends. Mom arrived home and found the child unresponsive on the couch, immediately called 911, and emergency medical personnel initiated rescue breathing. The child didn't respond to naloxone en route to the hospital. And with toxicology screening, we found fentanyl and norfentanyl. There was no oxycodone in that child's specimen. And so that's what's happening on the streets these days. We have drug dealers that are able to obtain pill presses, and they are making counterfeit pills. They look exactly or nearly identical to what you would expect a pharmaceutical medication to look like. So they might have the same inscription as the pharmaceutical tablet that you'd obtain from the pharmacy, with the manufacturer's logo, even the numerical designation, that sort of thing. The DEA and CDC have put out multiple public service announcements on this. Now, 5 or 8 years ago, they weren't quite getting the coloration of the tablets correct, but more recently, the coloration is more correct. So in the top here, you see a blue tablet labeled M30, and that would be a 30 milligram oxycodone tablet manufactured, I believe, by Mallinckrodt. And this would be the fake or illicit tablet. And in 2017, in Atlanta, Georgia, a woman was indicted in federal court for production of counterfeit oxycodone pills that contained fentanyl and other synthetic opioids. More recently, the public is coming in contact with not only the fake oxycodone, but fake Xanax bars. And Xanax often comes in a round or oblong shaped a tablet, often referred to on the street as a football, but they're also produced as bars. They are scored so that you can easily break apart and use just a quarter dose or half dose if you need. And this is an example published by the DEA of a counterfeit Xanax bar. Even our college students are succumbing to the effects of fentanyl and dying from it, because many college students will seek out Adderall in order to maintain alertness while they're studying for exams, and that type thing. And our drug dealers are pressing out fake Adderall tablets, and they contain fentanyl. Now, again, fentanyl is very potent, and it's approximately this amount, approximately 2 milligrams, or the amount that would fit on the tip of a very sharp pencil. That is enough to kill an adult human. In this image of tablets below that is still in the cellophane, I took a photograph of these tablets. These are illicit fentanyl tablets that were confiscated by our local law enforcement, and I took this image at our local crime laboratory. So for laboratory professionals, there are immunoassay screens available now that are specific for not only oxycodone, but also fentanyl and fentanyl analogs. There was one published or produced by Immunalysis that Dr. Marion Snyder reported on in 2011. And more recently, Dr. Grace Williams and colleagues reported on the comparison of fentanyl immunoassay from ARC Diagnostics and Immunalysis for their detection of 58 different fentanyl analogs. And very surprisingly, one of those detected 57 of the 58 that was tested. The other was, I believe, detected 51. So I would encourage laboratories to bring in specific immunoassays like this, because these, even though they're third-party assays, you can program them on your general clinical chemistry analyzer in any hospital laboratory. In regional toxicology laboratories or reference laboratories, we use more complicated instrumentation, but we determine specific drugs as well. So this would be an illustration of a gas chromatograph, where a drug mixture or patient sample is injected into the injection port. The drug binds to the column and elutes to the detector, and different drugs elute out of the column at different time points. So we're able to send individual drugs to the detector at different times. We can select a single drug, which would be exemplified here as a peak. And using mass spectrometry in combination with the chromatography, we can fragment that compound, and it will result in charged ions that are that result as a fingerprint specific to that drug. And it is the combination of the retention time and the charged ion fragmentogram that gives us positive identification. This is the gold standard method for drug identification used in the forensic realm today. So for laboratories, recommend use specific immunoassays, and if you have the capability to use GC mass spec or LC mass spec, I recommend that you use that. Our pain management service and pain management clinicians across the country love laboratories that are using these confirmatory techniques. Because you can imagine if you prescribe an individual with chronic pain, hydrocodone, for example, and they're tested with an immunoassay for the class of opiates, that individual may be positive, but he may be taking not only the hydrocodone, he may also be consuming oxycodone or heroin or something else. And so with GC mass spec and LC mass spec, we are able to identify the exact drugs and metabolites that the individual is taking, as well as to confirm that no drug would be present in those individuals that may be diverting their medications and selling them on the street. Now, there are several point of care devices that may be used as well. And I referred to strips, but there are also cards as well as cups. So different type formats that may be used in outpatient clinics, as well as home use. The CDC is producing a SAFE program or a harm reduction program that has gone into effect in the past couple of years, and they are providing fentanyl test strips to most public health lab departments across the country. It's available in all 50 states as a harm reduction strategy. They're not condoning the abuse and use of illicit drugs, but it allows individuals at home or on the street to test their drug for fentanyl. So in this format, this would be a little strip. As illustrated here, you would hold the strip on the left. A portion of your tablet would be dissolved in water or other matrix, and you would dip the strip in that water, and bars appear similar to your home pregnancy tests. For individuals at home or clinical providers for rapid detection, there are point of care devices such as these, and there are many different manufacturers. Some are actually dipped into the urine, like the two on the left. The others actually require drops of urine be placed on the card, and then these function very similar to your home pregnancy test that we're all familiar with, and results are provided in about 10 minutes. These can be purchased, as well as the cup format. These can be purchased at local pharmacies or online commercial enterprises for home use. And so if you have a child or a relative that you suspect is using drugs, you can purchase these and have conversations with those individuals and that sort of thing. Another way to prevent drug overdose, those are ways to prevent drug overdose. Testing drugs before you use them, as well as monitoring individuals and confronting them or talking to them about drug use and getting them the help that they need. If an individual has overdosed, there is a rescue compound called naloxone. We might refer to it as an antidote, but it's formerly known as a rescue agent. It is in the police cars and ambulances and in possession of every first responder. Clinical laboratories often have it on hand if they are handling illicit drug materials and analyzing them. But the federal government has made a program available so that there's a standing pharmacy order for naloxone at every pharmacy or in every state. Not every pharmacy participates, but the average layperson can purchase nasal naloxone from local pharmacies. And a link to an instructional video is illustrated here that you can clip and use. But essentially, the individual who has overdosed should be put on their side to avoid aspirating vomitus. And this compound is squirted into their nostril. And there are 2 doses in each box of nasal naloxone. These are sold for approximately $100 per box, but it ranges from location to location, anywhere from $50 to $150 per box. I can cite many stories of individuals who have been rescued from this. I think I related 2 here, but highly recommend that individuals who have a family member that is abusing or a friend that they suspect of abusing to obtain some nasal naloxone just in case they might need that. At this point, I believe that's the end of this presentation, and we're just about out of time, and need to remind you that support for this program is provided by Abbott, and I am presenting at the request of Abbott.
Wonderful. Thank you, Dr. Kyle, for your informative presentation. We'll now start the Q&A session of the webinar. If you have any questions you'd like to ask, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for today. Let's go ahead and get started. Question number 1, where and how can I get naloxone if I suspect a friend or family member misusing opioids?
Again, naloxone can be obtained from local pharmacies. It may also be obtained from public health departments in each of the 50 states. There is a cost to that, but $100 is a small price to pay to save, to prevent someone losing their life.
Of course. All right, our next question here is, why is fentanyl now encountered and sold more often than heroin?
Again, answer to that is that heroin requires that individuals raise those poppy plants and cultivate them, and then extract the resin from the heroin, or the sap, if you will, and then extract the drug out of that. And so that it can be very labor intensive, whereas the fentanyl and fentanyl analogs and others are simple synthetic products that can be produced in any large laboratory operation or processing operation.
Okay, thank you. We have another question here. How is quality control performed by drug dealers?
That's a great question. We've noted that quality control is non-existent by the drug dealers. Working with local law enforcement and our crime laboratory, it was related to me that in a batch of pills confiscated from the street, that some of those pills will contain just a trace amount of fentanyl, whereas the fentanyl in tablets from the same batch, same package, if you will, knock the roof out of the mass spectrometers, overloaded. And so there have been reports of drug dealers mixing these compounds in like cement mixers, like you would see at a job site. And so there is no quality control that's performed. I was communicating with our local Drug Enforcement Administration agents, and they said that drug dealers actually like to have someone die from overdose every now and then, every month or so. And this seemed illogical to me. And I asked them more about that, and they said, well, suppose you're an addict or whatever, and you hear that Mr. X passed away from overdose, then you know that his dealer had something that was very potent. And in your mind, that's what you want. That's the good stuff. That's strong. And so it actually increases their sales if someone dies every month or so. Just anti-logical to us, but that's the thought processes of drug dealers. It's all related to money. They don't care about human life.
Wow. All right. Our next question here is, what if a friend or family member has overdosed on opioids, but I don't have Noxalone or naloxone?
And that's a great question. Again, the opioids reduce the activity of the brain and central nervous system. People die because of the respiratory depression that's associated with that. They simply stopped breathing. So if you have someone that you suspect has overdosed on opioids and you cannot wake them up, you might try rubbing your knuckles on their sternum. That's called a sternal rub. It can be kind of painful, and that often wakes individuals up in our emergency department kind of thing. But if you can't wake somebody up, they're not responsive and they exhibit this agonal breathing, or if they're not breathing at all, simply the first thing to do would call 911 or have someone call 911, but then administer rescue breathing if you can, if you are able. And rescue breathing, very similar to that or exactly that as taught in basic life support courses and CPR courses. So you would breathe for that person until emergency medical personnel could arrive.
Thank
Great
you.
question.
Yeah. We have another question here. Is there a way for the average Joe to test street heroin or pills for fentanyl? A friend wants to know.
Yes. Again, the CDC has a program, a harm reduction program, in which they supply fentanyl test strips to each of the 50 states. These may be distributed in certain addiction centers or injection sites, or they may be distributed by local public health laboratories. They can also be purchased online or at your local pharmacy. So it's advised that individuals simply take a fraction of a tablet or dissolve a whole tablet in water or other solvent and then test that water with that test strip for the presence of fentanyl. Now, you need to know that not all synthetic opioids react to that. There are others like tianeptine and U-47-700 that may not react to that because of different chemical structures. But at this point in time, the primary offender that we're seeing in the public is fentanyl and fentanyl analogs. So contact your local health department for more information on that.
Thank you. And it looks like we have time for just one more question here. What should I do if I suspect my child uses drugs?
That's a great question. You need to have straight talk to your child, with your child, about the dangers of drug use and abuse. You can pull stories or reports from the local media about deaths of individuals. There was recently the death of 2 college students, I believe it was in Wisconsin, and they caught the drug dealers associated with those 2 deaths, and they had kilogram quantities of fentanyl. And again, the drug is so potent that it's hard to get a good mixture. And so some tablets can kill you, and other tablets may only cause a rush. But lots of people are dying from these potent synthetic opioids, fentanyl and its analogs. So have a sincere talk with them, warn them of the dangers. You may, if your child is still in middle school or something, you may say, hey, Johnny or Susie, we're just to let you know, we're parents, we own the house, and we're going to drug test you every month, or we're going to randomly drug test you until you graduate and go to college, that sort of thing. Or if you have a child that has been in rehab before or dealt with addiction before, you may provide that to them in order to keep them accountable. So there's several different ways to do that, but you definitely need to have a heart-to-heart talk with your child and warn them of the dangers of these illicit opioids.
Absolutely. Thank you again, Dr. Kyle, for your time today and your important research. Before we go, I wanted to ask, did you have any final comments for our audience today?
Only final comment is to be aware of the potency of these compounds. Be aware that there are methods to detect these compounds, not only by your hospital laboratory, but things that you can use at home. And so many of these things are free. If there are injection sites, or if your public health department provides a needle exchange program, those locations will likely be able to provide fentanyl test strips for you, but don't hesitate to reach out to some of the commercial online sources that you may be aware of. And protect those people, protect your loved ones, protect your friends.
Well said. Thank you, Dr. Kyle. We would also like to thank Labroots and our sponsor, Abbott, for underwriting today's webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during our on-demand period will be addressed by our speaker via the contact information provided at the time of registration. This webcast can be viewed on demand. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.